bonjour à tous. So yeah, we have a little bit of time finally because we're in advance. So we know when we start. We'll see when we arrive. So let's go. Avance. Yes, I will present you maybe a decade of work, starting from crash, from ground zero, how to develop a new brand of drug, of molecules to treat Duchenne muscular dystrophy. You know about Duchenne. I mean, I'm sure you have heard. It's a very severe neuromuscular disorders which affect boys because the gene DMD is located in the X chromosome. So the female can be carriers, but are quite healthy. But the boys are Duchenne. And so the clinical symptoms arise by the age of 2, 3. And they go worse until the age of 10 when the boys lose ambulation. And then usually, I mean, they have a cardiac and a respiratory failure, meaning that when I started, there were almost no adults, very few adults with Duchenne. And now, with the care, I mean, the nursing, many of them reach 30 and some in their 40s. There is no approved therapy, I mean, to cure. There are approved therapies, of course, at the FDA, but to cure, working, not to my knowledge. There is only the corticotherapy and some drugs that, for example, the ICE to treat preventive for the cardiac problems. But today, there is nothing that allows to rescue the dystrophin or to rescue completely the phenotype of Duchenne. There are innovative approaches that are ongoing, and I am sure that you heard about. It's the very first was the stop codon read-through. It was Ataluren. It was marketed in Europe, not in US, but it was cancelled recently. It doesn't work at the end of the day. Gene therapy, you have heard about AAV macrodystrophin. There are several companies promoting trials these days. And actually, there was a problem 2 weeks ago with Pfizer. A boy died after 1 year after having been treated with AV9 macrodystrophin. So it's a real concern. But there is also exon skipping. Exon skipping can be achieved by using gene therapy means, but can be done also using antisense oligonucleotides, synthetic antisense. So there are a few of them that are ongoing trials for different exons. You will see which one after. And one is marketed already in States, not in Europe because it doesn't work. So there is still a lot of space for this kind of drugs. The rationale is clearly established. There is no problem of that. The problem is a problem of chemistry and efficacy. So what is the rationale for exon skipping? I mean, this rationale is pretty old. Yes, about 30 years old now. It arises when Lou Kunkel discovered the DMD gene at the end of the 80s. And when physicians just discovered at the time that two muscle diseases were concerned by the same gene, Becker muscular dystrophy and Duchenne muscular dystrophy. Duchenne is very severe and fatal, lethal. Becker is much less. And there are individuals with mutations in the DMD gene, which cause Becker, who are almost asymptomatic. So here you have an example of what is the gene, the healthy gene, with 79 exons. Here the colors indicate the phasing of these exons. You know that there's codons, 3 nucleotides for a codon, and depending how the codon is shared in between adjacent exons, you may have blunt codons or codons that are shared by the two successive exons, either one base in one exon and 2 base, or 2 and 1. And this is very important because in Duchenne, most of the mutations are large deletions, like here. This boy, for example, miss exon 48, 49, and 50. So it's delta 48, 50. So you miss this part. And you see that the colors here of the exons, it's blue and yellow, meaning that you have a frame shift during the translation. So there will be a stop codon somewhere here, and this protein is not stable and disappear, so loss of function. Loss of function are lost. In the Becker situation, this one is this man, this old man, is 4851. 4851, it means that it's the same mutation but bigger. Here it's blue and blue. There is no frame shift, and the protein can be translated from the beginning to the very end. Obviously, it is shorter. A piece of the protein is missing, but fortunately, Duchenne is like, a protein that where you can remove. There are 24 repeats that are very homologous, and you can remove 1 or 2 or 3 or 4 or many repeats while you maintain some activity. So this protein is not perfect in the case of Becker, because this is still a disease, is Becker, but the protein does the job. And there are persons, many in French we say histoire de chasse, concerning patients with such kind of deletions. For example, there are patients with delta 51, 52, so 2 exons are missing, so they should be Becker, and they are fully asymptomatic. These guys with 48, 51, many of them have normal life, and they are spot men. So this is a good pattern. So we have the demonstration, it's like making a transgenic, if you want, that if you remove the 51 in this patient, you turn him into a Becker. So this is not restoring the normal dystrophin. It's just moving from a very severe form of the disease to a very mild form. So it's a benefit, but it's not turning Duchenne into normal. So how to make it? Because this is, now we have CRISPR-Cas9, etc. We could remove exon 51 from all cells. It's not so easy. And maybe I have something in the eye. So this can be achieved by using small drugs during the splicing. So here you have, so here on the left, the small cartoon is just to show you what is the splicing. It's a very caricatural, but it's a kind of cathedral, many SNRPs and proteins are involved in order to recognize what is an intron, what is an exon, and then splice this piece of intron. The goal here is just to mask this extra exon with an antisense in order to avoid this definition, and then the splicing will occur from this donor site to this acceptor site. It looks easy, but it is not so easy. And in addition, here we have a problem that this piece of DNA, its size and its very nature is unknown, and it is different for every patient, because the deletion is just where the 2 cuts are, and sometimes can be like that, like that, like that. What is sure that the exons contained in the missing part are known, but not what is remaining from each part of the 2 introns are still out there. So this is the theory. Now in practice, these antisense oligonucleotides, I mean, they are known now from the late 70s. In the 70s, you have already papers talking about that. There are artificial DNA. And the challenges are stability at different points, stability, target engagement, safety profile, and tissue delivery. So the very first, so the stability, very first. At the beginning, people used DNA, single-stranded pieces of DNA, and when RNA and DNA handed to each other, it triggers the RNase H, and it degrades the RNA, the mRNA. So it was okay, like a gapmer, to knock out a messenger, but not to manipulate a messenger. For that, the modification, we have to enter modifications in order to make that these artificial guys, when they anneal to RNA, do not recruit RNase H, and work just as steric blockers, just masking the different motifs on the mRNA that are involved in the exon definition. So the very first modification concerns the sugar moiety. Here you have classical DNA, for example, and so either by playing at the 2' here, either by meeting a 2' or methyl or methoxyethylene or whatever. This is our 3-cyclo-DNA. You see that there are 3 carbons here in addition, so they're different. So here we play on the sugar backbone. And there is other modifications that concern the internucleotide linkages. Here it's a phosphodiester and can be changed in phosphorothioate and many things. And there are also another class, which there is no sugar at all. It's the PNA or the morpholinos. All have advantages and disadvantages. So there is no perfect bullet in the field. So the second point, when you have a chemistry, you prefer chemistry, and this, in that case, here's the 3-cyclo, so you have here these 3 carbons here that make the 3 cycles. This guy was created by Christian Lehmann at the University of Bern at the end of the 90s, or during the 90s, and it's quite complicated to make that guy, these 3 carbons. There are more than 20 steps of synthesis, starting from the mannose. So it's not so trivial. It's just not just engrafting 3 carbons like that. This chemistry is very promising. We published it in Nature Medicine a few years ago. And it was developed at the beginning in Bern by Centena, and now, today, by Sky Therapeutics, Saint-Quentin-en-Yvelines Therapeutics in Versailles. So when you have this chemistry, it protects the RNA, it can do the job. Then we have to find where to engage. So we have software now, old, where we can identify canonic motifs for binding of proteins or SNRPs or whatever, enhancers, silencers on the messenger. This is very theoretical, to tell the truth. It's like an election course for the French. You know what is election course? I would say in French, I don't know how to say it in English. On bourre l'urne, on la jette à la mer et on discute après. So bourrer l'urne means play with the softwares. We have some targets, we play, doesn't work, and we start working à la dure, meaning that screening. So we have these putative regions, they're only putative, and we synthesize collections of libraries of oligos covering this region, and we test them on cells. And for example, many of them, most of them, I would say, are not good. We miss. You know, it enriches them perfectly, but has no effect on the exon definition, the exon you want to target. And sometimes you are lucky, you have one, which is good. And sometimes perfect, very perfect. And then you're skipping. And here is the example for Sky51, the one which is now in trial. Here you have cells from a patient with a deletion 4850, as shown previously. So untransfected, you have one messenger after RT-PCR around the deletion. And when we sequence that amplicon, indeed, there is exon 47 and exon 51. There is a frame shift, and there is a good size, etc. So this guy is really Duchenne, and there's a link between 47 and 51, very clean, without extra nucleotides that could provoke another problem. After exposition transfection, to make it easy, to 51, to Sky 51, we have this new band that arise, good size, it's delta 51, in addition to this one. And indeed, when we sequence this band, it is now in frame, and it's 47 to 52, exactly what we want, like in Becker. So once we have that, we have to deal with tissue delivery, because it's the same problem as presented just before with AAV. I mean, it works in vitro, it works, the rationale is perfect, but you have to deliver everywhere. In our case, is whole body. So we should use the systemic pathway, the bloodstream. And you know that this is quite dangerous sometimes to inject something in the bloodstream if it may have consequences. So first of all, the choice of the backbone, PO or PS, phosphodiester or phosphorothioate. There is pro and cons. Usually, for many chemistries, the pro is that it increases stability of the backbone, because the PS is artificial, so the enzymes it's more difficult for the endonucleases to cleave a PS than a PO. So it's good. So if there is more, there is enhanced biodistribution also, and you will see why after. And there is improved efficacy because more resistant, better distribution, therefore better efficacy. So PO is not bad for stability and safety profile. In the case of tricyclo, it's not true for other chemistries, but in the case of tricyclo, it's fine. The cons is that they are fast. There is a fast clearance from the blood, meaning that you inject your piece. So it's very expensive for a very poor efficacy at the end of the day. If we add PS, you improve the efficacy, but at the same time, you improve toxicity. So you have safety issues. And it's very easy to understand that on this slide. Here we compare all the proteins from the serum that bind these oligos, different chemistries, different sequences, depending if there is PO or PS internucleotide linkages. So here you see all the proteins from the blood that binds tcDNA or 2' methyl oligos, whatever the sequence, all the proteins from the mouse serum and here for the human. Basically, they are very similar, at 90% the same. And we thought to patent that just to purify the proteome of the blood, because you put that, you pinch, you have everything. So no, it was very perfect. If there is PO, so the phosphodiester, the same sequence here, it's Teflon, like with the morpholino. So the sulfur has a property, because it's bigger, the charge is more exposed, it's negative charge, to catch all the positive proteins, all the proteins that are positive with positive charge, and to keep it with that. This is why the oligo in the presence of sulfur is kept in the bloodstream for longer. With PO, there is no protein, it's Teflon, flush. Here you have the proteins in the mouse, from the mouse, and when you check their quality, I mean, it's a complement, the thrombosis, I mean, it's just all the proteins you don't want to fix or to activate for safety purpose. So this is for the mouse, and almost the same for human, except the guys who are here in orange, which was problem, because these proteins can be very toxic at the end of the day, and indeed they are. So what are the basic specifications we choose for SKY51, for our lead compound for the clinical trial and for the drug development? So it was basically a 15-mer oligonucleotide with 14 tricyclo-DNA. Here with a combo, we call it combo, it's a 2' methyl, classical, just to, because these chemistries, tricyclo chemistries, are constrained chemistries. The backbone is constrained. Therefore, it has, fortunately in our case, the exact shape of RNA. And an antisense made of tricyclo-DNA gains 2 to 3 degrees Celsius per nucleotides versus RNA. So it's very, very sticky to RNA. It has the exact shape, the angles of the curve. But it is so sticky, so constrained, that you may have off-target. So to avoid that and to improve safety, we introduce a combo. It means a kind of a rotule, an hinge, you know, that can turn and make that the probability that 2 tricyclo-DNA, even improperly, fit one with one or off-target with RNA is greatly decreased. We use PO and not PS, obviously, for the reasons you have seen before. And but if you put PO, it is flush. So in order to keep it into the blood and to deliver to muscles, we engraft here palmitoid residue, fat, in order to, the oligo is taken in charge by the fat transporters such as albumin or apolipoproteins, whatever. Here, just some safety issues before in vitro. We do that before because we had so many surprises in the past that we have something which is very promising until we go into we get into the animals. That it's always better just to start with human blood first, because if it's compatible with human blood, we can take the risk to develop the thing. If we start with mouse, monkeys, etc., until human, and there is a problem in human, we spend a lot of money, a lot of time, and at the end, it's good for mice, it's good for monkeys, but not for humans, so we lose time. So first thing is, do we activate the complement or not? So here you have the results. This is the PBS, so control. This is the Sky51, not different from PBS. And in the presence of sulfur, you activate the complement as much as with the zimosan, which is the positive control, the activator of the complement, and the same for the clotting. Here you have the clotting assay with the PT and the APTT for the both extrinsic pathways and intrinsic pathways. And Sky51 is fine in both cases, while in presence of sulfur here, you have an anticoagulant effect. So this is a proof that our design so far was not so bad. Then after we look for the real interaction with the protein of the blood, you have seen before that we had all the proteome in presence of sulfur. Here it's much more discrete. We have in the mouse basically ApoE1, apolipoprotein E1, which will target the oligo to the liver mainly. And in the primate, human or macaque, whatever, we have principally the albumin, which is a protein that binds our oligo, and very few for the apolipoprotein. And this is really something which is very different. We haven't seen that very often. And this is a singularity of this oligo. The sequence itself can bind to the human albumin, and this is what is shown here. This is the human albumin and the Sky51 here with the palm in the pocket, the hydrophobic pocket of albumin. And here the oligo can bind directly with as an affinity here to the protein itself, while in the mouse, I don't show the picture, but in the mouse, you have the pocket here, and the oligo is free and it is there. The very consequence is that the KD is very different. The KD, using a Biacor, can be assessed, and the KD is 10 times higher with the human lower, because it's negative, for the human albumin compared to the mouse albumin. And this is visible during the PK analysis. Here we injected the different doses. In the mouse, 50, 100, and 300 milligram per kg, and in the macaque, 25, 75, and 150 milligram per kg, and measure at different time points the clearance of the oligo in the bloodstream, and you see that the kinetics are very different. In the mouse, at 24 hours, you have almost clean in the blood, while in the monkey, at 24 hours, you still have about 40% of what you have injected, and 1 week after, 168 hours after perfusion or injection, you still have 10% of the oligo, meaning that there is a long-lasting delivery process. Here you have just the model, so you inject and this is the distribution. So it's clear here at 25 milligram per kg, which is the Noel dose in the macaque. And here you have clearly the distribution phase and the redistribution corresponding to the elimination from the tissue. So the model, at least in the monkey, is that the 51, Sky51 is injected into the blood. It binds to albumin. With albumin, it will stay days, circulating, almost not found into the urine. It stays in the blood and enters into the tissue. When it is in the tissue, the Sky51 loses this palm residue. There is a depalmitylation, and it becomes delta palm 51, which is a real drug. Before, it's a prodrug. Sky51 doesn't work. If the palm is still attached to the oligo, it doesn't work, or very few. Once palm is removed, the antisense can reach the nucleus and do the job, and does the job. Part of it, of course, goes into endosomes that can be secreted or directed to the lysosome where they're destroyed, and we see the N-1, -2, -3, etc. it's visible in the tissues. And the delta palm in the bloodstream has no palm. It is PO, so it can be possibly reptech at very few, but most of it is extracted in urine, and we found it obviously here, and not in the monkey because it's quite difficult to do this kind of analysis. They are not very compliant, but in humans, we will see after it's more easy. This is what happens over time, so I ran the curve. So here is 40 injections. This is during the tox study. So the animal is always exposed, and there is no, I would say, side effects. I mean, remarkable side effects. And we see that the oligo is still present in the blood. There are very few Sky 51, I mean, the original drug in the tissue, but there is a delta palm. And these levels, of course, are very high in the liver and the kidney. We try to detarget that, but it's very difficult because the objective is to have enough oligo in the heart, diaphragm, and different skeletal muscles. And actually, it goes much better in the heart and not bad also in the diaphragm than the other muscles, which is good for us because the main target, I mean, Duchenne is systemic disease, okay? You have to treat the brain, muscle, the kidney, everything. But in the case of these patients, the most important is to treat the diaphragm and the heart. This is the cause of death, not because you can't move the fingers or don't feel well in the head. It's really diaphragm and heart. What about pharmacodynamics? I said before that this oligo has to enter into the muscle, find a messenger, bind to it, skip 51 in order to frame the messenger. This is for Duchenne. Here is the contrary. Here, the messenger, the original messenger, is in frame, and when skipping 51, because it's exactly the same sequence in human and primate, we destroy the reading frame. Delta 51 is Duchenne, it's not normal. Therefore, we are doing the contrary, was turning a normal individual into a dystrophic individual, which is very complicated. If it works well, it will be toxic. I mean, turning someone normal into Duchenne is not a good thing to do. But this is what we do here. And we analyze these animals after 14 injections once a week, and we analyze the levels of skipping. So this is 14 once a week, and we see here the level of original messenger. So with the 51, and here is delta 51. This messenger is not stable because it is subject to the nonsense-mediated decay. Therefore, the result here it's underestimated. I think that in Duchenne would be the inverse. The original messenger is subject to nonsense-mediated decay, while the corrected messenger would be more stable. So it's likely that these numbers can be higher in patients than in the monkey. And here is the design of the phase 2. We will see in the phase 2 we plan to make bulks of treatment, blocks of treatment, 4 weeks treatment, 4 weeks off, 4 weeks treatment, etc., etc. And in order just to protect the patient from protect his venous capital, because every week injections every week is very painful for this patient. So if we can just spread the perfusions would be better for them. And it is not bad. I mean, we have something which is quite similar. These levels of skipping and the numbers are quite similar. So this is very encouraging. Question now is what would happen in human cells. So here this is done by a researcher in the lab. So he's making mini muscles. I call it almost because they are very big. They are 1 centimeter long. It's almost ex vivo biopsies because we construct muscles that can eventually contract in 3D. So here, this is a normal muscle. This is made with delta 52 DMD cells. So this is Duchenne, and this is the same, but exposed to 51. Just you put into the soup, and you remove the next day, and you check what happens 1 week after, or 1 month after. We have done different things. So here there is a PCR. So the size of the DMD messenger, so normal. Here, obviously, it's delta 52, so here blue and yellow out of frame, and the same in the presence of sky 51. 51 is removed, now it's yellow, yellow. It's shorter, it is here, but there is some protein. This is capillary western blot, so here this is the signal for dystrophin. There is no dystrophin in the DMD before treatment here, and after treatment there is some. And we can see it also by immunofluorescence by sectioning the thing. So it's very encouraging. If we have this level of dystrophin, I'm sure that it will be beneficial for patients, even if the signal is quite faint compared to the normal signal. So what about now the trial? We started the trial 1 year ago. It was, first injection was in June 23. So it's a monocentric. It's 12 patients, adult and pediatric, ambulant and non-ambulant. We didn't want to make classes or stratify, just a type of Duchenne and not the others. We wanted to check the safety at all ages, at all stages of the disease, in order just to have data for everyone and continue for everyone. So this is done in a single center at Garcia, and all the hospital is working on. The endpoints are obvious for the first-in-man. It's safety, and safety, and we'll compare each patient will be his own control and to baseline. We'll compare the data at the end to the baseline, and this is the design of the phase 1, because this is a kind of personalized medicine. So we don't know if all patients will be, I would say, will tolerate the compound in the same way. Maybe some patients will not tolerate and others will tolerate very well. So why just stopping for the guys who tolerate the molecule, because some do not. So it's good to start with a dose escalation, all patients. And I think that for every new patient, we need to have this dose escalation, starting from 2 milligrams per kg until 25 milligrams per kg. Theoretically, it's every 2 weeks, but in fact, it was longer because there is always problem in the hospital, etc. But this is, and of course, because it's safety, a lot of blood samples for biochemistry, complement, clotting, everything you can imagine until there is no blood in the body. And what was very important was to check, because human is not a monkey, but we are very close. You have seen that we bind the same proteins in the bloodstream, and we are very different from the mouse. The mouse, the oligo disappear within 24 hours. In the monkey, it's there for 1 week or eventually 2 weeks. So it was very important for safety issues to verify online, as soon as possible, that the Cmax, the maximum exposure during the injection, were not higher than what observed in the macaque. And this is what you have here. You show here. This is at 2, 4, 6, 10, 16 twice. Here, this patient received twice 16, and then 25. And this is the Cmax of the monkey at the same dose. So we are quite linear, which is very good, and we arrive at the same point. So we have a conclusion: human is a primate, or the primate is the non-human primate is still a primate. We analyze the pop PK just to check the constant, the secondary parameters, and they are very close of what we have seen in the monkey, meaning that after 24 hours we still have 40% of the oligo in the bloodstream. 1 week after, still 10%. So it mirrors what happens in the monkey, and the time here for distribution and are the same order of magnitude. What was very important that in human it's more easy to collect urine, so we could analyze the presence of the unchanged oligo, what we injected, and the prodrug after depalmitoylation during the kinetics, the time here during the 2 weeks between the injections. And what we have seen is that about 1 to 2% of the injected product is recovered in urine, not more, meaning that 99 or 98% of the compound stays in the body, where it would be depalmitoylated. And half of it, or 40%, will be recovered in the urine over 2 weeks. The point is that 51 is very stable in serum and urine. We knew that from in vitro, but we know that also from in vivo. It doesn't change. And the scale 51 is a prodrug, and the product to conversion occurs only in cells, not in the urine, not in the blood, and this is very important. What are the objectives now? So here we have almost finished. We have 10% have finished the phase 1. Only still 2 remaining to start. We hope in the weeks, in the 2 weeks, next weeks, and then we expect to finish the phase 1 by the end of the summer, and then we will close that phase and publish that phase. And we are authorized. I mean, we are pending for the final decision, but would be in a few days to start the phase 2 with the same patients, and then would be the same objective, except that there will be a biopsy at the end of phase 2, and then we'll check for the presence of dystrophin, mRNA, etc. And this is the design of the phase 2A. So the patients will receive 4 injections, once per week, at first cohort 10 milligram per kg, the second cohort would be 16 milligram per kg, and the third cohort 25, with 4 weeks off, etc. And here's the muscle biopsy. According to this is a simulation with the parameters we got from our test. During 1 month here, the patient will be exposed, continuously exposed to the compound, meaning it's not just a bulk of oligo and then during 1 week nothing. The oligo would disappear slowly from the blood, distributed in the tissue. So we're confident that after 4 injections, if you know your weight, calculate 10 milligram per kg, you multiply by the number of your weight, and then by 4, and you will see that the amount of oligo is not neglectable. So we'd expect that with that level of oligo, we should have something. And this is a sum up of the full study. So it's very long, it's very ambitious, because there are 12 patients. In many trials, you have 1 injection or a couple of injections, and then it's all. Here we have 12 patients, and each patient will have at least 40, how many here? I don't see the number. 49 weeks, so 41 visits, yeah, plus additional visits. So it's very long per patient for each patient, and there are 12 in the same place. The very first part here in phase 1, we wonder about safety, because these kids are very fragile. So we are performing this phase 1 in the intensive care unit, in adults for adults, and pediatric for kids. And we keep the boys at the hospital overnight, and we keep them for 2 days almost. This is for the phase 1. Phase 2 will be in a day hospital de jour, and will be more easy, faster, etc. But there's still many patients the same day. So we guess that this will be, we finish that. It will take a year and a half to complete completely the phase 2. And last but not least, what do we expect in this population? We have 12 patients, but they are not equivalent. And of course, the drug substance is Sky51, is an antisense, but the real medication is not 51, is the final protein, the dystrophin, the rescue protein. And as you have seen, there are many genotypes are eligible for 51. So you may have the same efficacy for skipping the exon 51, but at the very end, what the cure is the presence or absence or quality of the protein. And depending on the genotype, you may have here different pieces of the protein that are missing. So delta 4351, for example, the protein will be very different from a delta 5158. It's not the same pieces of the protein. Maybe the protein will be at the same level, but they are very different in quality. Maybe one is working very well, and the other one is not. Therefore, you'll say, oh, if the endpoint is presence or absence of protein, fine, we can conclude. But if the endpoint is it clinically beneficial? Could be different. Therefore, because there are so many genotypes, so many states of the disease, and so many proteins at the end, it's very difficult to make global, I would say, statistics. And what would be very important is to see for each patient the personal benefit in function of its own protein, because at the very end, it's its own protein. We rescue its own protein. And to finish, this is I would like to acknowledge all the participants to that project, and I'm sure that there are more. So there are people from Sky Therapeutics here, they are close to our lab. Here, people from our research unit. Many of them were before in the research unit, and here is all the clinicians and nurses and other person involved at the hospital level, and here are our collaborators. I thank you very much for your attention.